Cek, mic 3 dicoba. Cek, mic 4 dicoba. Mic 4 dicoba. Cek sound mic 4 dicoba. Cek sound mic 3 dicoba. Mic 2 nggak dipakai. Cek mic 1 dicoba.
Cek. Cek suara dari mic wireless.
Sound mic 4 dicoba. Cek sound mic 3 dicoba. Cek mic 1 dicoba.
Cek suara dari mic wireless. Jelas. Sound aman.
Udah terhubung nggak ke jam tangan atau ke ini?
Aman.
Atau kamera? Coba ganti suaranya keluar. Ya, ada sama satu orang bantu kamera itu. Oh ya, jadi kalau kurang ini. Oh ya, nanti saya minta arahkan aja. Saya nanti minta arahkan aja. Di sini. Kok pakai sendiri gitu? Kan kurasa tadi. Ada suara bocor. Ada suara bocor dari ninjanya, guys, ninja itu ya, ada pakai manis ya, iPad itu. Kalau mute mute pasti gede dia. Ini suara dari mana? Dari sini. Entah dari masuk sini atau masuk sini. Kan bahasa Inggris kayak di US, mungkin nggak mungkin lagi masuk sini kan? Ini suara apa ya? OBS Ninja ini belum commit ya? Oh iya. OBS Ninja itu masuk udah tadi. Nggak paham. Oke lah, dadah. Masih. Oh ini baru OBS Ninja, baru ngomong OBS Ninja-nya nih. Kan harus kritik. Ya. Delaynya 3 menitan.
Ya.
Itu Nyala semua.
this?
No, like this.
This way?
Yes.
Like this? No? No, no. Okay. Yeah.
More comfortable.
Oh, you do that for me, yeah? Okay. Yeah. And perfect.
Ini pointer which
Yeah. Okay. Thank you. And you have my stick for later. Okay. Good. Anytime.
Okay. Good morning to all the participants. Good morning to Professor
that's
Zundert. We will start our today's workshop. Our workshop today is about the ultrasound guide, regional anesthesia on live model. Okay, so without any further ado, we will start our workshop today. We will like to first say thank you to Professor to have give this opportunity for us to learn together. So now the time is yours, please.
Okay. Everybody can hear me clear and loudly? Wonderful. Thank you for devoting your free time on a Saturday to come and join us. But I think it's a very useful day for you. Not too often you can see so many blocks, regional anesthesia blocks, as this morning, I guess. And I'm going to overwhelm you with a lot of information, but I hope you can pick up things and so that you can improve your own practice by practicing on patients later on. So please excuse me. For me, this is a new machine. I'm not used to that one, so sometimes I will be struggling with it, I guess. Yeah. But anyway, I'm sure there are helpers who are going to help me out with any problem. Of course, there are many of you. Usually I give these kind of workshops in small groups of 5 people, for instance, so that they can look around here and look directly what I'm doing. But today that's not possible. So we have opted for a system where we project everything on the screen. Now, I hope I'm not sitting in front of it because it's not that high. Is that the best option then, to sit here in the middle? So if I sit here, can you still see everything on the screen? Yeah. Okay. And make it as big as possible, please. Can you make it as big as possible, because they need to see it? Yeah, I mean, this should be as big as possible. If you're ready, then okay, good. Perhaps you can switch from time to time where there's a need to show it more in details. Okay, good. Now I would like to ask Jin to come forward. Is Jin in the room? Is Jin here? Yeah. Regional anesthesia, you need a number of things. First of all, a good equipment. Without good equipment, you can't do anything because you don't see in an optimal phase. This is our hero, Jin. Please give him a warm applause. Without Jin, I could not do and give this workshop. This is impossible. Yeah? Jin, I had a little chat with him yesterday and a little bit of practice yesterday. And the first thing to do always is to make sure that the patient is informed about what you are doing and informed consent, because you're going to use your hands on a patient. And I think it maybe would be better to take this off, yeah. And we are going to expose him, yeah. So you need to ask the permission of the patient. You need to ask the permission of, yeah, to touch the body of somebody, okay? Always do that. Be friendly to your patient, yeah, and say, I'm going to touch you, yeah. So, but he knows that already. So it's very important to have a good life model, to have a good machine, and to have good support. And the support is from you all, and the technical support, I presume somebody from the guys will help me as well. Regional anesthesia is about knowing the knowledge of anatomy. Yeah, we are just applying our knowledge of nerves and arteries and veins and muscles and sympathetic chains and you name it. We are applying that to make sure that we can take away the pain. Now, regional anesthesia is unique. You just put some local anesthetics and it does the job. It is the best painkiller of all. None of the opioids, none of the painkillers we know are as good as our local anesthetics. So local anesthetics, if you do it the right way, they will stay in a specific spot. They will not do the whole body, unless you're going to give a huge spinal anesthetic, but that's not the intention. So you give spinal anesthesia, epidural anesthesia, combined spinal epidural, all the paravertebral blocks, you name it. I'm going to concentrate today only on the peripheral blocks, not on the central blocks, but on the peripheral blocks. That's already more than enough to fill this whole morning. Okay? The first thing to do is make sure that the patient is comfortable. The patient should be comfortable, so give him a pillow, yeah, and make sure that he lies in a comfortable position. Now, should he lie like this, or should he lie like that? This one, huh? Yeah. So make sure that he sits or lies in the exact position that you want. Yeah, not like this. That's not a good position. I will show you in a moment. It will blur your image. That's not what you want. Okay, so a good position is with the patient lying like this. Okay, that is what we want. Legs next to each other in a relaxed, comfortable way. Okay, so it's best to have the pillow like this. Okay, but you have a lot of space now here. If you want to do an upper extremity block, you have a lot of space. If you have a lower extremity block, you have a lot of space. This is what you want to do. So you do not want to have a pillow like sitting like this because you have no space anymore. Is that clear? Yeah. So that's how we want to do it. Yeah, and lie flat. So in the first instance, make sure that he just lies in a position, in a very neutral position. Yeah? Not like this, not too much like that, yeah, or this, just in a neutral position. That gives you the comfort for the patient, but also the comfort for yourself. Now, the best thing to do is that you face all the time the patient. I'm sitting here, yeah, and you will see some colleagues say, no, I sit here and I do the block from here. You can do that, but then you miss some vital parameter of what a patient will tell you by just looking at his face. If something goes wrong and you inject local anesthetics into a vein or an artery, he will not say anything because he feels lousy, but you will see it. Okay? So if I'm standing here, I don't see it anymore. So the best thing to do is always face the patient. Always look at the patient's face and tell me if something is going wrong. If you feel not optimal, lousy, whatever, just tell me, okay? Because I'm aspirating all the time before I inject. but nevertheless, you're not 100% sure that something goes intravascularly. Good? Now, we have to start. I've prepared some slides. So we will do a segment and then we go to the slides and show you more the anatomy in the ideal situation. So first thing to do is to know how this is going to work, okay? We know on the machine, that's the right side. Always check that you're on the correct side, okay? Okay, just a little bit up, that's it. Now the first thing to do is look into the thorax. To find your important vessels, the first thing to do if you want to do an upper extremity block, look into the thorax. I'm going to do that. So I'm in the thorax now. You see that? Yeah. And what can I see? What do I see here? What do I see here? The subclavian artery. Very clear, isn't it? You can't miss that. So go into the thorax. That's the first thing to do. And if you have it right, so this is my right side of the image, this point, sorry, the left side I must say, but here on the median side. Yeah, this is the median side. So I see here the artery. What is this then? What is that? This part here. Can you take a deep breath? Okay, and out. Do you see the movements here? So that's the lung, the pleura. Okay? So that's an important aspect of your block, that you are not going to pierce the pleura, because you do not want to have a pneumothorax. So it's good to know that. So artery, pleura here. And what is this then? What is all this? Can you see it? It's like a bunch of grapes. Can you see it moving? What is that? That's your plexus. Isn't that easy? Just go into the thorax. Yeah? Don't start here, don't start anywhere else, but just go into the thorax. Okay? Now, you have to do something for me. Feel, you have to feel yourself all the time. So feel yourself here, just next to this place, and take a deep breath. Can you feel the pleura? Okay, so anything that you are going to inject above the clavicle on the medial side, there's a little chance that it's going to end up in a pneumothorax. So be aware of that. Yeah? So that region, especially this region here, you need to avoid. Okay. Now what can I do? I can use my needle. Yeah, this is my needle, a blunt one. Yeah, you can come from different sides. So maybe I can do it this way. I can come from that side, yeah? So from the lateral side with my needle, okay? And this is the first strip. Yeah? So I come from there and I inject already a little bit of local anesthetic on this side and a bit on the upper side. And you will see it creates a little bit space around this here. But I will never go too far away that I will end up in the artery. I need to see it all the time, yeah? So I need to see the whole length of my needle, and for that reason you have to use all the time a little bit of movements with your ultrasound machine, okay? So that you can see the shaft, but also the point, that's important. And when you inject a local anesthetic, it should create some space around it, okay? This is already in the mid position. The mid position of the plexus brachialis. That means I'm pretty sure I will have the whole hand, the whole arm. Okay, so this is the Coulombkampf technique. Now they called it in the past, but look, there are so many names. Forget them all. Yeah, the way is to know where to go with your needle in which spot. Okay, so if you have to operate upon the whole arm, yeah, then just come from that side. Okay, you still can go in the midline here, but that's not what I want, because I only will see just one piece. Yeah, so don't go this way, but always come from the lateral side here. Okay, that's one thing. Now, the next thing is, can you, yeah, now I'm going up a little bit, and I'm going up towards the ear. So I'm lifting, can you see that? I'm going up. And what do I see? What are these vessels? What are these? If I push hard, it's gone. Yeah. And if I ask him, just can you give a push? Yeah. You see the difference? So it's very important to know these little kind of tricks. Yeah. So where are we? So this is the vein and this is the artery. And what is this little thing in between? Which nerve is that? There's a sheet around the vein and the artery, and just in between the two is the which nerve? The vagal nerve. Okay, so the vagal nerve is in between. I will show you that later on. Good. You actually can see sometimes the valves. There's a valve in there. I'm not sure whether I can demonstrate it today, but yeah, sometimes I clearly can see the valves. I think I see one here, but this is not that important at the moment. What I see here, this is a big muscle. Okay, a big muscle. This is the anterior scalene muscle. Anterior scalene muscle. You see that? Okay, and this is the median scalene muscle. And there's also a posterior one. It's a very small one, not interesting of us, so we disregard it. Yeah, but it's over here. Sorry, it's over here. But in the meanwhile, you see there's the plexus. See that? There's your plexus, and move it. You see, ultrasound is a moving thing. It's not a static thing. It's dynamic. Yeah, you can do with small movements. You can improve your image to the best and optimal position so that you can put in the needle in the correct position, but visualize it. I'm a fervent defender of visualizing in anesthesia. I started with these things already 25 years ago. Yeah, and I worked in Eindhoven. Eindhoven is the mother city of Philips. So I got the best equipment possible. And that made me that I could make all these nice, beautiful images over the years, as you can see them here. It took me 2 years to really make a structural function of these blocks so that you can do it in a structured way, and especially if you want to teach it. Okay, so we see here the nerve. What kind of nerves do we have here? See, 4, 5, 6, 7, 8. At least 7 C's, 5, 6, 7, and 8. That is what we usually see in here. There's also a nerve on top of this one here. Oh, I'm not 100% sure I can find it right now. So just in front of the anterior scalene, which nerve is that? It's an important nerve. Sorry? The phrenic nerve, and the phrenicus, the phrenic nerve, and that is innervating your diaphragma. Okay? So if you're going to do a block on both sides and you anesthetize both phrenic nerves, that will give problems with breathing. So be careful for that. Okay? So you see the nerves, and I really can go from the lateral side with my needle, and I inject the local anesthetics here. Not there, but here. Okay? Again, it's a dynamic function. You just move it in and out a little bit. Don't stay at the same place all the time and aspirate each and every time before you inject something. That's important. Okay, so it's clearly to be seen here between the anterior and the median scalene muscles. Okay, so this is important that you see this vein and artery. So can you clearly see that the vein, yeah, the vein is next, sorry. This is the artery, the carotid artery, this is the jugular vein. It is next to each other almost. There is some overlap. Now, if you look in patients, you will see sometimes, especially in the obese patient, that it is in a vertical line, anterior position. So the vein lies anterior. Oops. Do I do something wrong? Okay. Thank you for helping me. Yeah. So sometimes the vein is just in front of the artery. Make sure you're not going too deep into that, yeah? Because you will end up placing a catheter into an artery. And sometimes, and especially in the very big obese patient, BMI of 60 or 70, there's such an enormous amount of fat here that if you have helpers had to take away to make some space, yeah, and the fat is coming back, it pushes the needle deeper. So be aware of that. Yeah? So there are accidents where even a correctly positioned central venous catheter ends up in an artery. So be aware of that. Okay, now what kind of surgery can we do here with this kind of block? Now we are high up, and I want to say what is the anatomy here? The anatomy here, what is this? This is which nerve? Sorry? No. I want to have the skin innervation. So the ones you're showing there. So this is C2, okay? So this is C2. C3 is here. Can you show it? Is it clear? So above your Adam's apple. That's C3, okay? C4 is below the Adam's apple, okay? And then, how should that, can you go and stand over there? Because then it's important that we know the anatomy. It is important when the surgeon is going to operate upon that you know exactly which segment you need to anesthetize. And if your block is not 100% sure, correct, that you can add on little things, yeah, so that you can make it even perfect. So this is C4, okay? This is C4, C5, C6, your thumb is C6, okay? This is C7, and this is C8. So please remember that. Okay, so if you want to find out whether a nerve is intact, ask him to do radial, median, ulnar. Very simple things. Ask your patient, put up your thumb, put up your middle finger, put up your pinky. Okay, so now I know my ulnar nerve is intact, my median nerve is intact, and my radial nerve is intact. What happens if it is not intact? If you have anesthetized the correct nerve, what will happen? With the radial nerve, drop hand. Okay? You cannot do this movement anymore. With your middle finger, it is like a sign like this. And with your, can you see it? Sorry. Yeah. Yeah. And with your ulnar nerve, you will have a sort of like this. You cannot bring it up anymore. Okay, these are the things you need to know when you're doing a block and that you can find out before and after. Always test it before you're doing anything. Okay, ask him, can you do this? And you immediately, within 3 seconds, you know the 3 nerves are working fine, no problems whatsoever. Now I'm going to anesthetize him, and then I want to find out whether I can really block these nerves. And we can do that. Yeah? So remember, C4, C5, C6, C7, C8, T1, T2. Okay, that's important. In fact, what has the creator done? This part has been taken out of this part here. So we have C2, C3, C4, yeah, and then it goes all the way down T1, and then we have T2. So from this point here in your axilla to this point in the axilla, that is T2. So if you're going to find out a central block, how high it is, you always know it should never go beyond this level here. If it goes higher, then the patient will say, I get pins and needles, yeah, in my fingers. Then you have a high block. Be careful then. Be prepared maybe to intubate the patient. Yeah? So this point to that point, that is T2. Okay? This is, the nipples is T4. The umbilicus, 10. Excellent. Then we have the inguinal area, L1, yeah. The knee, it depends a little bit, but on the medial side, L3, L4, yeah. What is a little toe? Sorry? S1, that's correct. The big toe, L5. Okay, you need to memorize that. I can't help you. These are facts that you have to know. So again, yeah, this is the upper thoracic level, T4, T10, L1. You're perfect students, I must say. Yeah, so it's easy. Okay, I did not mention C1. Where is C1? Okay, that's for your arm. Thank you. Where is C1? Have you never anesthetized C1? It's a joke. There's none. So there's no C1. So this is all C2, yeah, C3, C4, and then all the way around. Okay, so now you know where you have to operate upon. Yeah? Now it's important that you also know the distribution of the nerves. Now, which nerve is this one here? This part. So this part here, this one. It's very unique. It's a musculocutaneous nerve. So if you're going to block the axilla, for instance, sometimes, because it takes off very high, you will miss it. Okay? I will tell you how to block it. So it's important that you know which area the surgeon is going to operate upon. That is so important. Eh? So if he's operating upon here, you have to do different things than if he's operating here. That side or that side. So the whole anatomy is so important to know, and you have to really pay attention to these things. Okay, next thing. Any questions, please ask me. Eh? So you know the interscalene, that is for shoulder surgery. Okay, the supraclavicular one, that is for surgery of the whole arm. Everything is blocked. If you go to the axilla, then it's more for the distal part. Okay? And then you can also block the individual nerves. So even if the block after 10 minutes is not optimal, and you see, okay, the ulnar nerve is not working, I do an extra block on the ulnar nerve, or the radial nerve, yeah, or the medial nerve. And that's what we are going to show right now. An easy block, in fact, is also the following. I forgot the marker. Do we have the marker here? Thank you. Okay. Now, an easy block, and this is a combination of feeling and using the ultrasound. The acromion here, can you see it? And we have here the clavicula. Okay? So from this point here, that's the medial side, and please feel it yourself. Huh? Feel it yourself, yeah. From here till there, okay? You make a line and you go halfway. So it must be somewhere here. That spot, that's easy to do an infraclavicular block. Now I can show it to you, but it's very difficult to show it because it's deep. We have here which muscle? Pectoralis, yeah? And below that, the major and the minor pectoralis muscle. So that's already a thick layer. So if I take my needle, I can do a perpendicular block here. Now look, my two hands here. Can you show it? Yeah. This is the thorax. You see the thorax? And look at my fingers. Yeah. Where that mark is. You see the mark is outside the thorax. Can you see that? Yeah. So if I'm going to do a block in here, I can block it without producing a pneumothorax. Okay? It goes in deep, like this. Yeah. Perpendicular. But you can find the nerves over there. I will show it on my slides how to do that. Okay? So make sure that you find your way. Yeah? And if I do this, you see there's a little tip here coming above the clavicle. And that is where the lungs are. So we need to avoid this space here. Okay? That's forbidden. Never put anything in there. Even if you're doing a supraclavicular block and you want to do it with the puncture this way, never go too medial. You will end up in a pneumothorax, guaranteed. Now the next thing is we go to the axilla. Can you move a little bit towards there? That's easier for you. Yeah, and I'm putting it down like that. And put up the fingers like this, not like that. Okay? Don't ask the patient to lie like this. Why not? Never ask to lie like this. In, I think, 20-25%, the artery will be blocked. So don't do that. Make sure that he lies like this, with the hands, the front up. Okay? Now I'm going to sit down. Okay? And I'm looking in the axilla now. See that? Okay. Yeah, that's fine. Yeah. Need more. Where's the shell? Yeah. Yeah. Okay. With the pointer, so the yellow mark up. The yellow mark up, and this is what you see. Let me find out. Okay. Now, I will show you images later on, and there are many veins here. It's an abundance of veins, but also a few arteries. So the chances to go intravascularly is pretty high. Now, what can I see here? I see a major vein, which I can collapse. See that? So a major vein, oh, sorry, a major vein, and this is the artery. And this is another vein, okay? Or another artery. Now, the relationship, you can see this is the biceps, and below the biceps, so this is the biceps, but below the biceps is the brachial muscle, okay? So biceps and brachial muscle. Between the two, what do we have? What do we have between the two? So this is the biceps, and this is the brachial. So what is this here? Can you see that? It's moving. If I move my probe, I can see it's moving as well. Okay? That is the musculocutaneous. That's that nerve that branches off very quickly. So it's not going along with the other nerves. So that's important that you show that here. Okay? So you have to block that separately. So again, come with your needle. Oops. Come with your needle like this, yeah, and go. And go, you come from that side and you go and block it here. Very easy, a few cc's and it's enough. Okay, and then we go to the rest. What do we see here? This is the vein, this is the artery. What is between the vein and the artery? Which nerve? Yeah? The ulnar nerve. Okay? So the ulnar nerve, now you have to think three-dimensionally. Yeah? The ulnar nerve will always sit here, in between. And the median nerve is on top. It's much more superficial. And on the other end of the bone, you will see the radial nerve. So we see here the musculocutaneous. We see here nerve structures. Usually I can find the radial nerve here, the ulnar nerve over there, and the median nerve over there. Okay? Provided you have your point, this one here, yeah, upwards. If you're going to use another technique with another direction of your probe, it will all change. So make it standardized. That's what I'm trying to tell you, a standardized way of approach of each of these nerves. That's important, okay? So it can be difficult from time to time to know that. You see little branches are here as well. See that? There's a little branch here and a little branch over there. Most probably both of the musculocutaneous nerve. Okay, but you do your block, you come from the side, yeah, you go and block here the ulnar nerve, the radial nerve, and the median nerve. Okay, you have to move little by little to find out which it is. The better quality, you will see it better. I'm sorry, but there are machines that cost $200,000 as well. Huh? So, yeah, that's unfortunate. That's the economic law, and I cannot change that. Good. That's in the axilla. Okay. Always see the point of your needle and inject the local anesthetic around the vein. Yeah, that's what you want to do. Now I need you to lie the hand like this. Now I'm going to have a look. Yeah, what is this nerve here? Please feel it. It's in a groove, and you actually can move the nerve. Okay? Can you feel it? So make it like a right angle and feel with your finger in the groove. And you actually can move it. Now there's only very limited space. That's the ulnar nerve, of course. There's only limited space. Go up 2 centimeters and block it over there. Okay? So now we are going to try to block single nerve. You have done already the musculocutaneous nerve. Now we are going to block the ulnar nerve. And to do that, go up just 2 centimeters. That's free space. Here's very limited space. You do not want to end up injecting something and there's so much pressure that the nerve is destroyed. That's not what you want. You can do it, but be very careful. Yeah? Okay, just go up 2 centimeters. Now what I'm going to do right now, can you lift it a little bit? Where is my pointer? Oh, here. Yeah, okay, good. Just lift it a little bit, yeah. Okay, what do I see? The first thing is, what you see is clearly a bone. Okay? So this is the ulna bone. Yeah, and there you see the ulna. See? That's not difficult. Yeah, and yeah, you have to wiggle around a little bit and inject some local anesthetic around it. How much local anesthetic? 5 mils is more than enough. 4 or 5 mils. Okay, so for individual nerves, very limited amount, but make sure that it is all around the nerve. Okay, that's that one. I'm sorry, he needs to have a bath afterwards. Now the second one is, can you hold this for a moment? Yeah. The second one is, now we go and look here at the elbow, okay? So we have found already the ulnar nerve. Now we are going to find the brachial artery, and next to it is the median nerve. Okay, can you come? So we are looking for the brachial artery. Can you see the brachial artery? And the nerve, I think this is, no, this is it. See the brachial artery now? Okay, so using color vision helps you to provide the, and you immediately see also the nerve on top of that. Huh? That is the median nerve. Again, use your local anesthetic just to freeze the area around the median nerve. So that's also easy. The other one, what do I see here? This one here. 2 branches of the radial nerve. Now you have to do me a favor, because many people do not know that. Yeah? Oops. Yeah. Your elbow, you know this muscle on the lateral side. Now feel just here. Feel. Push almost here. It's not pleasant. It should not be pleasant. Okay? That's your radial nerve. So very easy to find it here. The radial nerve. This is superficial and a deep branch. But you have to block them both. And if you see it here, it's in fact very easy to distinguish. There's nothing in the neighborhood, so there's a superficial and a deep one. So just block them with 4 or 5 cc's, and that's it. Okay, so the elbow is a very easy place to put in your needles and to find the exact distal nerves. The next phase is this one. I just go in the middle here, and I immediately find which nerve. So I'm now in the middle of my underarm, I need more, more hands, I guess. So I'm now just in the middle here, just right in the middle, okay? That's what I'm doing. I make it easy, I just go like this, yeah, and there he is. Yeah, so it's that easy to find the median nerve. Good? Ugh. There it is, okay? And you can follow it up, yeah? And there are two tendons. Can you see that on your arm? The palmaris longus, yeah? These two. And just in between the two, what is that nerve? There's the median nerve, okay? So even if you inject local anesthetic between those two, you will block the median nerve. Again, I think very easy, isn't it? Just a couple of cc's, it's enough, because the nerves are the thickest here, and they, well, become thinner and thinner and thinner. And at the end, they will be very tiny, because there's not too much to innervate anymore. So, yeah, that's it. So, you see, that's my nerve over there. Easy to find, it's just in the middle of all kinds of muscles, and then you go down. Yeah, and try to follow it. Try to follow it all the way down. See it over there. And now it's coming much more superficial. Yeah. When you're here, yeah, then it's almost very superficial. Okay? So don't go too deep in here. How many tendons do we have here? How many tendons? All kinds of tendons. How many? 9. 9 tendons. And you have, if I just go here, can you distinguish them? It's impossible. Yeah, it's impossible to distinguish between tendons and the median nerve. For that reason, always go in the mid place. Yeah. There's no need to go and block it here. Go here. It's much easier. There's only one nerve. All the rest is muscle. And you avoid injecting something under the, what's the name again? Retinaculum, fascia retinaculum. You don't need to do that because that's a very restricted one. And people sometimes suffer, remember, because fascia retinaculum is too tight and the surgeon has to cut it. Des Kervin, these kind of diseases. Okay, so go here. It's much easier, no problems. You inject around the nerve and you have all the branches, because what is happening, the nerves, they split all the time. They give branches off to the regions, etc. And they innervate pieces of skin. So do it here, not here. And just to show you what's happening here. Yeah, now I'm looking at the radial side. There's the radial artery, but it's not showing up as yet. There it is. Okay. It shows the color blue and red. Yeah? And the nerve is, sorry, and the nerve is on that side. Now the nerve, can I give it to you? So that's the radial artery, Okay? And the nerve, where is it going? The nerve is going here, in the anatomical sniff box. So the nerve is going into your anatomical sniff box. That's one of the 2 branches. But you always will find it here, because it needs to do this. Yeah, so it needs to go in here. Now for the ulnar nerve, the radial artery, that's easy to palpate. That's no problem. And you find your nerve on the outer side. For the ulnar artery, sometimes you can't feel it. It's more difficult. but the nerve is always on the medial side. Okay? Now, you feel that little bone here, the os pisiforme. Now, the nerve goes over the os pisiforme. So if somebody falls and makes a half a centimeter incision here, the nerve can be cut. So half a centimeter, yeah. So be careful if you're going to cut in that region, because you really will cut an ulnar nerve. That's not what you want to do. Okay, so I will try, but usually it's so small that I can't find it anymore. Yeah, I see something. Do you see the red one? Yeah, and next to it, yeah, next to it should be the nerve. But again, it's so tiny that it's better to inject some local anesthetic and you're done. Okay? Good. Any questions of that? Yes.
Professor, I'm Felix from second year registrar. I want to ask about the use of peripheral nerve stimulator. Do we need to use nerve stimulator also to block? Although we have seen nerve well, the images, do we still need the nerve stimulator, and how we combine the use of both modality? Thank you.
So your question is about the innervation of the skin, the muscles, the bones. Is that the question?
For doing the blocks,
Yes.
do we still need the nerve stimulator to combine with the safety to not injure the nerve?
Look, I have a long career behind me, and I started doing all the blocks feeling. There was no nerve stimulator, there was no ultrasound machine. So we had to learn all the blocks just by knowing and feeling. Okay? But I even did celiac block, sympathetic blocks, yeah, without any technology. Can you imagine that? So we did all these blocks. Because I was in an institution where they did an enormous amount of blocks. In my first 1.5 years, I did more than 1,000 epidurals. 1,000. And my first year, I did 150 blocks, supraclavicular blocks, just to give you an indication how many we could do. And that gave me a lot of, well, support to know much better how to feel it. And then later came the nerve stimulator, and much later the ultrasound machine. Now I still think there's a place for a nerve stimulator. If you're not sure, why not using the nerve stimulator? Yeah? If your machine is not optimal, then you need to make it better in your hands. But if you have the best quality machine, I think there's no really need for a nerve stimulator. But I've done it in thousands of patients. There are days that I do 20 of these blocks. Yeah, to give you an idea. Okay, we have done this now. Maybe we go over to the slides. You can sit up and see them as well. Yeah, have a look. Yes, sit up here. So I prove to, can you bring it up a little bit, or is that difficult? Or you sit there, yeah? Is it possible to bring it up or not? I think the last rows will not be able to see it. Is that correct? It's difficult, huh? So what I try to do today is to give you simple evidence of where are nerves located and what to do and in which situation. Yeah, because you can't read this, you can't study this from textbook. This needs to be taught, yeah, on mannequin, on models, etc. You cannot lift it, you cannot bring it up here, because the latter, if it is too difficult, they have to stand up.
Professor, I'm sorry. May we have a break for 5 minutes so we could
Okay.
have a snack?
Yeah, that's fine. A break?
We will have, before we start the slide and Professor will start the slide, we have break for 5 minutes.
Yeah.
Yeah.
Okay.
Yeah.
See you in 5 minutes.
Thank you.
So I am. Can you bring up my first slide, please? The first slide. Yeah, that's much better. Can you put a weight on the back? I hope I did not create a problem. How's it going?
Yeah.
Not too long. is it?
Yeah, this video is
10 o'clock already. Going fast, huh? But there's so much to tell everybody. So. You enjoy it? You enjoy it?
Yeah.
No, I will take care.
Because we do the camera on Zoom.
No, I will pay attention. Do you have a little? You have a little clock like this, not bigger than that. So I put it over my hands. Yeah, a piece of cotton. That's like this.
Oh,
Yeah,
so you can.
so I can put it on.
Okay, I will.
You have a cover? Sometimes a clamp would do. Yeah, that would be enough. A thinner one would be better. You have a thinner one? No, that's okay. Is it going well?
The screen is also, we show it on YouTube, so everything is okay.
Right.
We just need to
But
take
I
care.
mean, is the presentation, does it go well? Do you think,
Yeah,
they-
yeah. They're
can see it?
excited and they can see it. If they can, they can see it. So they can
thank you. I've produced a slide series to give you an idea of what the real best quality pictures would be. Okay? If you can start the presentation. Just the slides now. Okay, good. So you need to know muscles, nerves, artery, veins, yeah, and other things. It's not possible to put this as a big screen. Okay. It's not. Yeah, okay. So you really need to know all the structures in the body. You need to know the sensory innervation. And you know the skin innervation is not the same as the innervation of the muscles and of the bones overlying that. So the skin can be different from the bones and the muscles. Usually it's in the same area, but there's some overlap. Okay, we have told you about this. Yeah? C3, C4. C5, C6, C7, C8, T1, T2. The nipples, yeah? T4, the umbilicus, T10, this area here, oops, yeah, from your spine here all the way to the pubic bone, that is your inguinal canal. And often when I ask people where exactly is the inguinal canal, they go far too low. You have to be higher. Okay, we'll do that later on. Yeah, this is almost the same as that picture, where you can see C2, yeah, C3, C4, C5, T1, and then between the axilla, that's T2. Yeah, T2, T3. So we are lacking the 6, the 7, the 8, yeah, because they are all on the arm. Then we have the nipples, T4, T10 is here, and L1 is here. Okay? And on the back, you see C3, C4, C5, C6, C7, C8. So on the back it's correct, but not in the front. In the front we have the C6, 7, 8, yeah, all on the back here, but here they are in the arm. Then it goes from T1 to T12, L1 till L5, and then S1 till S5. Next. This is not working, yeah. Okay, so in fact, what is the anatomy? The anatomy is perfect if you have the position of the patient in this situation. So C3, C4, C2, 3, 4, 5, 6, yeah, 7, pink C8, T1, T2, and then it starts all the thoracic one, all the lumbar ones, and the sacral ones. Okay, and the knee is 3, 4, 5, the big toe, and the little toe is S1. Okay. Next. Okay, so you need to go into deep into the details of all the muscles. I'm not going to do that because it will take far too much time from me. But you have to, the reason anesthesia is applied anatomy. Yeah? It's no more than that. Next. Next, please. Yeah. So this is Alan Winnie. Alan Winnie was an anesthetist in the United States in the last century. I'm not 100% sure when he died, but he was a wheelchair person. So he did all his block sitting in a wheelchair. Very famous person, and he wrote these beautiful illustrated books. Yeah. I'm not sure whether you have these. Yeah, you have them? Okay. So as you can see in here, we have the cervical vertebra here, with the clavicular, yeah, and we have the humerus. And we see this is a sympathetic chain, the carotid artery, and above You see a little bit of the cupula of the lung, the artery, the vein, and then the plexus all together packed in a sort of a fascia. It's not a tight fascia. There are lots of holes in it. And so if you inject something, it will leak out also. Yeah? It's nicely done, but you see there are holes in it everywhere. Next one. Now, these are these overviews that makes our life a little bit difficult, I guess. It's not so easy. Next one. Yeah. And this is when I was your age. So I made it myself. You see that here? To understand it better. I had also difficulties, like everybody else, understanding this anatomy of this very complex area here. And what you see, these T5 till C8, plus branches from T1 and T2 and C4. That is the plexus. So mainly C5 till C8 with some adjacent branches. And they're coming out, yeah, of the vertebra. These are roots, yeah, trunks, and then they start to branches off. These are the divisions. And the moment you see divisions, you know you're already outside of under the clavicular. Okay, so the clavicle is here. This is the division. Then we have the cords, and then we have the terminal nerves. So we have the trunks, superior, middle, and inferior, and we have the cords, lateral, posterior, and medial. In fact, you should imagine that the artery is going in between here. And behind the artery is the posterior cords, that's your radial nerve. Yeah, we have the lateral one, yeah, and we have the medial one. Okay, that's how I try to understand it. So again, the roots, the rami, yeah, the trunks above the clavicle, below the clavicle, you have your divisions, then we have the cords, and then we have the individual nerves. Is it okay? Is this better? But I like the pointer here to put it down. Where's the pointer here? Where's the point? Okay, and the next one is here? Okay, good. So, roots, trunks, divisions, and cords, and then the individual nerves. Try to memorize that. I think it's important. Okay? Again, I think this one is a good one. You see C6 till C8 with adjacents T1s and T2 and C4. That produces a lateral cord, a posterior cord, and a medial cord. And the artery sits in here. So posterior, lateral, medial. That's how I remember it. And you have here the median nerve, the ulnar nerve, and some other branches. There are many, many, many branches. This is very innovative area here. Yeah. The posterior one, that's your, which nerve? The radial nerve. Huh? So the radial nerve always sits at the back, ulnar nerve and median nerve. And then we have from the lateral cord, we have that musculocutaneous. Okay? That branches off very quickly. So if this is the axilla and the musculocutaneous branches off very quickly, you will miss it. So you have to block it individually. Now it's easy to block, but you need to know where. Okay, so many of these things just to understand. Now you need to understand the sensory innervation of the hand. Yeah, the sensory innervation of the hand. So you split your ring finger in two. See that? In two. And that part is all median nerve. And this is ulnar nerve. But the median nerve also does the top end at the back side. See that here? This is ulnar, but at the back side, so this is median nerve, but also at the back side, the top fingers. Yeah? And then the radial, that's your thumb, mainly front and back, a little bit bigger on the back. Good? Well, different images about that. You see that here. So the radial nerve, that's the red zone. On this side, palmar vision, dorsal vision, median nerve, the blue one here, and the green one, that is your ulnar nerve. So if you're doing an operation on this side, well, you should not block the radial nerve, for instance. Very clear, isn't it? Yeah, another color, but in fact it's the same. So the blue is here, median nerve, this is radial nerve, and the green is ulnar nerve. Now there are many techniques. There's not one technique. So many people develop their own names, and I've taken off all the names because it's so confusing and there's no point. But you can do it, yeah, in all kinds of directions and all kinds of places. You can do it supraclavicularly, interscaline, infraclavicularly, and don't forget, this is that point, halfway, and you are outside of the lungs. Okay? So you can do that there. It's in a nice bundle here, together with the artery. So the subclavian artery is there as well. Did you feel it here? Did I do that already in the middle? Okay. So if you feel it just in the middle and you push against the first rib, that's the first rib here, it's not a pleasant feeling. But at least you know it's there immediately. So if you want to do a block in a sitting patient, for instance, how deep is it if you're sitting there? Can you feel it? How deep is it? It's hardly nothing. I've done plexus block on a 6-year-old. They're sitting on the lap of the mother. Yeah? You can do that. Yeah? Freeze the skin and then make sure that you do the block appropriately. Yeah? Sorry. Okay. So this is also very good to see it. You see the brachial plexus coming out. This is the subclavian artery in between the anterior and the median muscle, scalenus muscles. See that? It's like in an envelope. So what you need to do is you need to be in between those two muscles. If you are between those two muscles, you hardly have any problem whatsoever. So this is the common carotid artery, the jugular vein, the phrenic nerve, always in front of the anterior scalene muscle. And if you know that anatomy, then it should not be a problem. So this is the first rib, and the plexus is exactly on that first rib. If you go more medially, here you see the lung top. Not much, but just enough to have a serious complication. So here you see it again, the anterior scalene muscle. This is a sternomastoid, levator scapula, but for us the interest is the anterior scalene and the middle scalene, and the plexus is just between those two muscles, with the subclavian vein and artery in here. So the plexus sits here together with the artery. Okay, just have a look how it goes. So this is the plexus at different levels. You do understand this is a dynamic thing. It's not static. Good. This is an anatomical preparation. You see here, this is which muscle? Yeah, the anterior scalene muscle with which nerve? This is the good. And this is the middle, yeah, the middle scalene muscle, and this is your plexus, and this is the first rib. Okay? If you go more on this side, it will be the pleura. Okay? So I think I've taught you now a little bit about what is the plexus block, looks like, yeah? And it's a dynamic thing. So the nerves that we are interested in are always around an artery. Nerves need the highest concentrations of oxygen. a vein is not so important, so they are always left out. Yeah. So this is the musculocutaneous nerve. This is the brachial muscle. This is the brachialis muscle. So brachial and brachialis just below that. Then we have the bone, and then we have the triceps. The triceps is here. So the triceps, 1, 2, 3. You have the humerus here. This is your medial nerve, the ulnar nerve, and some other branches. And this is the radial nerve. So at the side of the triceps, you have your radial nerve. On the medial side, you have your ulnar nerve, and this is the medial nerve. And don't forget this one, the musculocutaneous. You really have to block it separately, otherwise you will not have anesthetized in full. So you see the musculocutaneous nerve is coming off below the clavicle, yeah, but before the axilla. This is a live model. What you can see here, we see now from the back, yeah, and what you see, this is the ulnar nerve, okay, and it goes in that groove in here. See that? It's coming in here. And the artery, obviously. There are many veins, the basilica, the cephalica vein, and this is your ulnar nerve. So all to be seen from the back, and this is your olecranon, yeah, and that's the groove. Now, we used to do these kind of blocks just using our fingers, without any ultrasound, without nerve stimulation. So we asked the patient to lift the head, and then you could see that the sternocleidomastoideus mastoideus was coming up. And you just went with your fingers, yeah, you lifted it up, and what you do then is making sure that you will see part of the plexus. I would recommend, this is the Winnie technique, but that's very old, I think 50 years old, maybe longer, I don't know anymore. But I will show you, it has also disadvantages. So you see the plexus in here, but if you are too high, then you are also anesthetizing other parts of the block. So what you do, and this is with the Kuhlenkampf technique, where you come perpendicular, yeah, or this is the Winnie technique, where you do it this way. And ideal-wise, you only stay in the direction of the plexus, but do not inject anything there, because that's your artery, and you do not want to have a toxic reaction, obviously. So the dangerous thing is, and you always have to aspirate for that, yeah, if you're injecting here, this plexus, that's fine, but please, yeah, what is this? Sorry? I can't hear. CSF, yeah. So this is a spinal. You do not want to give a spinal and inject 20 mils of local anesthetic there. You would end up with a completely anesthetized patient from top to toe, I'm pretty sure. Yeah, you do not want to end up in the carotid artery. Okay, so I think our technique nowadays is better coming from the lateral side and not going, yeah, vertical or really perpendicular. So I would suggest avoid this technique. Okay, so this is what's happening here and under number 3. So you're injecting local anesthetic here, coming in the plexus block, going in the spinal space, and going up and down. So complete spinal block will be the result. How much do we have in our subarachnoid system, CSF? What is the volume of the CSF normally? I can't understand you. Yes, just repeat it. That's correct, 150. What is the total production in a day of CSF? Around 500. So 3 times a day at least, we are renewing completely our CSF. That's a good part of it. But obviously, in 150 mils, and you're going to add on 20 or 25 milliliters, that is going to have a serious effect. So don't do that. So the technique of doing that, and you see this is lung here. Yeah. So the 2 fingers, Here, that's lung. You see how close you are? And a pneumothorax can be the result. So you need to know your muscles. You need to know C4, C5, C6, C6, C7. It should be this one here, and C8, and then coming back T1, T2. That is what you need to know. Obviously, you can test the sensory levels, the motor activities. This is your interscaline. Go first into the thorax and then try to understand what exactly is the anatomy of the patient. Yeah. This is what you can see. Yeah. What is this? Yeah, the pleura, and this. The first rib, okay? So the plexus is just above the first rib, and this is your artery, okay? So the artery, subclavian artery, the plexus is over there, always on the lateral side. On the medial side, you have your median scalene muscle. This is the pleura, and this is the lung. Okay, and your sternocleidomastoideus and the trapezius. I've not shown it yet there, but the trapezius at the back, and the sternocleidomastoideus is obviously this big muscle here. Yeah, just to give you more idea, and that's more or less, yeah, a picture of that one. This is the interscaline. Interscaline, you see the C4, no, C5, C6, C7, C8, and this is the phrenic nerve. Remember? So in front of the scalene, the anterior scalene muscle. Anterior, median, posterior. Posterior very small. Trapezius, and this is the sternocleidomastoideus, jugular vein, and carotid artery. Again, more in detail, but it's in fact the same. Okay? Interscaline, the phrenic nerve. See the phrenic nerve here? This is the internal jugular vein and the carotid artery with the vagus inside. And there's another fascia around this here, anterior middle scalene with the C5 till C8 nerve, sometimes a T1 in here. Okay? Again, the plexus structure. It can be difficult to differentiate, so you have to move it. The still image is not the best one here. Scalene anterior, middle, and the plexus in here. Sternocleidomastoideus, scalene muscles, and the plexus in between. Okay. Now there are aberrations. There are anatomy variations. The textbook provides the ideal situation, but the reality is different. All patients need to be scanned individually because there are alterations. I'll show you a few one. So this is the plexus block. These are the scalene muscles. Yeah, scalene muscles, plexus block. Just have a look. This is how it looks on ultrasound. It's a nerve. Yeah. Yeah. And here you see the nerve as well. And you have fascia. Yeah. See the fascia lata? There are different layers here. But it's clearly that grapefruit position of the nerves. Now, if you are in doubt and you don't really know it, just turn around your probe and there should be a continuing. You see that? There should be a continuing. A nerve never interrupts, of course. So that's how you can check whether it's really a nerve or another structure. Yeah. Variability of the plexus. As you can see here, the scalene muscle is coming in between the plexus. See that here? You actually can see it here as well. So that's the nerve, and that's part of the nerve, but the muscle is in between. Okay. This pectoralis major and minor, and then below. So we are now below the clavicle, and you see This is subclavian artery and subclavian vein, and the nerves are always around the artery. That's the same. So pectoralis major and minor, axillary artery, and the nerves are around the vein. That is what I told you have to do. Yeah. Just measure from acromion to the midline here, make one line, divide it into half, and you see you're outside of the thorax. So you can do an infraclavicular block here. It should not cause any harm, but it's quite deep. This is your axilla. See that here? With the 3 nerves around it, and this is the musculocutaneous nerve. Okay? Ulnar nerve, median nerve, musculocutaneous, and radial nerve around the artery. So make sure that the probe is facing upwards and that your needle is coming down, yeah, from above. Yeah, here you can see musculocutaneous. This is the ulnar nerve, median nerve, and radial nerve. The vein, the artery, median nerve, ulnar nerve, and here's the radial nerve and the musculocutaneous nerve. It's like a little bit of a ship that is walking back and forth. Yeah. Okay, we have seen this one and this one as well. There's some anatomical variation of the axilla and the nerves. You see here the triceps, lateral and medial head, and the biceps in here, the median nerve, the vein, the artery, the radius, and the ulnar nerves. But again, that's why you need the scanning, obviously. We have done that before. We know when the ulnar nerve is not functioning anymore, we have that ape hand. Yeah, this is the ulnar nerve. That's sort of a claw function of the hand. This is the radial nerve, and it's just a drop. Okay, you cannot lift it anymore, and it's a drop hand. And yeah, a few of these images. I'm not going too deep into that, but you do understand there's a lot of nerves around here. So you need the volume. The volume, the local anesthetic needs to find the nerves themselves. Okay? And the musculocutaneous, biceps, and the brachial muscle. And in between, you see the musculocutaneous. That's the only one you need to carefully look and anesthetize yourself. See that here? Another technique is, which I have not demonstrated, is this one here. Yeah. So you palpate your vertebra here. This is C6, C7, and midway those, and about 5 centimeters to the lateral side, you can find also the plexus block. So from the back side. Sometimes there are indications you can't have access on the front, and this is an alternative. We have the Pippa approach going in front, yeah, and the Boussard approach. There are so many techniques. Yeah, and what is happening? So we have the patient sitting in front of us. So this is the back side, this is C7 with the transfer processes. And what you do, you bring in your needle, you hit it, and you just go a little bit on the side and block your plexus over there. Okay? Avoiding going too deep. For that reason, your other hand needs to be in front and feel that there's no nerve coming. If there's a nerve coming, then you're too deep. Yeah? You do not want, you have to feel here, on this side, obviously, you have to feel here, and the nerve should not be, the needle should not be felt. So that is, for instance, in a patient, yeah, if the patient has such a position, I can't do a block here anymore. Okay, then the alternative is do it this way. Okay, with severe kyphoscoliosis, for instance, it can be very difficult to position the patient as a normal position. Okay, you see that in here. Okay, so you go, yeah, touch the transfer process and go a little bit on the side and you will find the plexus over there. But don't go too deep. So once you have found the transfer process, go a little bit to the side and inject your local anesthetic over there. Above the elbow, I've told you that. I'm not going too deep too much, but the radial one, the ulnar one, and the median one is easy to block in that region. So the ulnar nerve, you see the humerus here, very black, and just go on top of that, and that's your ulnar nerve. See that? Ulnar nerve. And ulnar nerve, yeah, it's over there. Okay. So you can block different nerves in here. This is the radius with the superior and the deep branches of the radial nerve. So just go in here. Biceps. Yeah, that's the radial nerve. Deep and superior branches. Very easy. Anatomy of the wrist. We have our 9 tendons here with muscles, and go for the median nerve over there. Okay, and the ulnar nerve and ulnar artery, they are so tiny that it's sometimes very hard to find them. Median nerve, and then we have that's also median nerve, and the radial nerve. Okay, just go in between those 2 tendons and you will find the median nerve here. Sometimes it's easy just to do a ring block, yeah? Because there are so many branches here, just do a little bit of a ring block. That we have all seen, and that was the result then on the plexus. Look very carefully, there's a right brachial plexus and there's a left one, okay? But we have seen all these images already. The success of regional anesthesia for the upper extremities: know your anatomy, the position of the patient, have the skills, practice a lot, yeah, and use the correct needles, maybe nerve stimulation, but ultrasound is the best way forward, I guess. Have a block room so that you can do it on your ease, not under stress, and the success rate must be very high if you're doing that. This is for the next one. Okay? Do you need another 5-minute break or not? We can carry on. Come on. Okay, so the next part is now the thorax, and this is much shorter. The upper extremity block, because it's such a difficult anatomy, it takes much longer. Okay, though. Just a few things that you can do, yeah, on the thorax. First of all, if you go to the ribs, you need to know what is the position of the ribs. So ribs, yeah, you feel them, okay? They are going like this, okay? They are coming from the back and there's an angle here. So the best way to block them is just behind the angle, okay? Now, if you have a rib here, and suppose my finger is a rib, where do you block? Where do you put the needle? Above or below? Above? Above? No, below. If these are 2 ribs, you go below. Okay? So you, in fact, what you do, you puncture your needle, okay, go in the direction of the bone, and then just walk off the bone. Now, there are 3 layers of muscles between those ribs. You only need to pierce a little bit, okay? And you have the vein, the artery, and the nerve over there. So be careful. It's one of the most, well, you can say that the absorption of local anesthetics is very high here, especially if you have to do more than 1 block. Can you do a cesarean section using just intercostal blocks? Yeah. If you do the last 6 ribs on this side and on this side, you can do a cesarean section. okay, without anything else. So it is possible. You can do operations here, just blocking 6 ribs here and 6 ribs here. It's very easy. And how much local anesthetic do you inject each time? 2-3 mils? That's all. Okay? So, but if you have a fracture here, it's good to go as far as possible behind that line here and do a few of the blocks so that it is covered. It is so much better for your lungs to recuperate that you do these blocks. It's really important. Yeah. So use your techniques. Use your technique in patients who have sustained a trauma. Yeah. To make sure that you can help them make it, especially the very older, the elderly. Yeah. These are not going to recuperate from a flail chest, for instance. It's very painful. Ribs that are broken and not aligned anymore, and many of them are the case. So these ribs, the fractures, these are causing a lot of pain. Either put in an epidural or you do these blocks here. That's so important. So go off the bone till you can go a little bit further, and that's where you inject your local anesthetic. It should be very easy to inject it. Always aspirate, of course. Yeah. Is it okay? So that's what you can do in here. You can have a look at the intercostals. See the, where's my pointer? So this is the rib, okay? And these are the muscles. So we have intercostal muscles, yeah? Interior, superior, and you just have to keep up very tiny. So you go underneath here, you walk off the bone till you are just under the bone. Yeah. Okay. This is normal structure. The beach waves, as they tell you, when there's no pneumothorax. And so you can diagnose a pneumothorax as well. Now we go to this region here. Now we are going to see whether it's an active boy or not. Mm-hmm. Yeah, whether he is practicing or not. You can see that. Okay, what is this muscle? Sorry? Yeah, the rectus abdominis muscle. You see that very clearly. I think he is a very good practitioner, because if you would compare that to mine, I know which one to choose. So this is the umbilicus region, and this is the other side. Okay, so this is the other rectus abdominis. You see the two fascia here? See the fascia here? If you put a needle in here, you can anesthetize the umbilicus. Yeah? So the only thing what you need to do is come from the side, put in the needle just in the middle, where you see clearly the two lines here. See, that is your nerve here. Okay? That is what you need to anesthetize, and the umbilicus will be, well, frozen. It will be good, I think, if you do that for surgery, even in children or so. It's very easy. Okay, and then you go to the side, you go further, and all of a sudden you see 3 muscles. You see 3 muscles here. One there, and one there. What is that? Excellent, excellent, yeah. This is the obliquus externus, internus, and this is the transversus. Okay, you need to know that. Why is that so important? Because between the internal muscle and the transversus muscle, we have nerves. Two important nerves. They are coming all the way from here and they're coming this way here. Which nerve is this one? This one. What is that? So it's coming all the way from the middle and the back this way. What is this? So just below the umbilicus. What is that? Iliohypogastricus. Okay, the iliohypogastricus is innervating this part here. From both sides, you have this here. Okay, so this is the iliohypogastricus, and this one below is the ilioinguinal. The ilioinguinal is the one, yeah, who goes to the groins. Yeah, so iliohypogastricus, this region, ilioinguinal will go to the inguinal region. So what you need to do is, there's one, yeah, and the other one is here. So the one who is most on the lateral side, that's the ilioinguinal one, and the iliohypogastricus, the more medial one. Okay, so the only thing what you need to do is make sure that you inject your local anesthetic just in between those two layers. The local anesthetic will spread. You will see it, that it is spreading. So it's spreading all the way around here. And that is good. So this whole area here, you can freeze it. You can anesthetize it. For all kinds of operations, yeah, in this whole area. Yeah. So that's important to do that. Can you just hold this? Thank you. Okay. Now, after spinal anesthesia and other regional anesthesia techniques, it is important that you know the bladder function. You have to follow up the bladder function. Are you doing that in the postoperative phase? Yeah, you have to do that because you never know whether there's a patient with a full bladder instead of 400 milliliters, which is usually the maximum. It can end up 800, 1000, and even more. I've seen patients with 1500 milliliters, yeah, in their bladder. That's not good. That can affect the rest of their lives. That can affect the bladder function for the rest of their lives. So it's very important that you have a machine just for a bladder scan in recovery. Okay, I'm going to do that right now. So you can see the bladder here, yeah. And I asked him not to go to the toilet so that it is rather full, I guess. Okay, but it's very easy to do that. Okay, make sure that you check that and that you actually can measure it. But the nurses, they know how to do that. Okay, so that's important. I need to hold this for a moment, yeah, and my pen. Oh, here it is. Now it's important for the next phase to mark two areas. This is an important one, the spina iliaca superior and anterior. Okay, I'll do it on this side as well. So this is a very important mark because now we need to go to the tuberculum here on the pubis, to the tuberculus on the pubis. Sorry. And this is your canal. Can you see it? So this is the inguinal canal. Now, if you're scanning it, if you're scanning this region, yeah, you need to stay in here. Far too often I see they are going too low. And why is that not helpful? Because the arteries branches immediately below this line, but also the femoral nerve, they branches off immediately. So you will not be able to freeze the nerve. So it's important to be aware of that. Okay, what we do next is this one here. Okay, so if I stay just on that line, and you see the arteries, you see the artery? See the artery here? There should be veins over here. Yeah. And the plexus block is always on the lateral side. Okay, so the femoral artery, it's clearly to be seen here. I can't compress it. Yeah, but if I go too low and I see immediately already two arteries. I see an artery here. It branches off. You see the splitting? Can you see it? Yeah, and the more I go down, the more it will be seen in branches. So you have to stay well above, yeah, in that region of the inguinal line. Yeah? So your vein over there, the artery there, and that's your nerve. So please, you need to understand this. Yeah? The nerves are always on the outside, yeah, the lateral side. The arteries are always in the middle, and the veins are always, yeah, on the medial side. So nerve, artery, vein, vein, artery, nerve. That is something you need to know, otherwise you're blocking the wrong side. Yeah, so that's important to do that. So again, come from the side with your needle, come from the side, and this is what you want to target. This is what you want to anesthetize. You have the fascia lata here. Fascia lata is just under the skin. Yeah? So you have the skin, some fat, and then there's the fascia lata. That's here. Okay. And then you have the fascia iliaca going around muscles and also around the nerve. So you need to hit through two layers, the fascia lata and the fascia iliaca. Again, come from the lateral side. You come from the lateral side, you will see it here. And inject some local anesthetic, go a little bit further, and you will make a split around the nerve. That is what is happening, okay? Is that clear? So that's the only thing to do, but don't go too far, because otherwise now I don't even see an artery anymore, and I'm only maybe 1.5 centimeters below that inguinal line. Correct? Can you hold it for me?
Yep.
Okay, good. Sorry for the mess. I told you I'm very good in making a mess. Okay, good. I need to bring this up. The next one, so this is a femoral nerve. Oh, I forgot to say the lateral cutaneous nerve. We have that mark here, okay? Just a finger towards the medium size and another finger upwards. So 2 centimeters more medial and 2 centimeters more upwards. Can you hold this? you feel the layers. This is the normal cutis and subcutis, but then you feel a layer. You feel a fascia. Okay? Just pop through that fascia and inject your local anesthetic, and what you will have anesthetized is then this part. So any operation from the knee to here will benefit from an injection over there. That is the lateral cutaneous femoris nerve. Okay, it's going up here. So your spina iliaca anterior superior, 2 centimeters to the medial side, 2 centimeters more towards the cranium. Feel the fascia, go through it, pierce the fascia, and inject your local anesthetic, and you will freeze the whole area here. Okay? The next thing is obviously the obturator nerves. The obturator nerves and the femoral nerves, they have the same origin. Yeah, they have the same origin, but they innovate different things. Now the femoral nerves, I forgot to tell you, the femoral nerves are important aspects from the upper leg and the patella. Yeah? So any operations in this area is going very well. So any operation that is in this leg or in the patella, that can be done with a femoral nerve block. Okay? If you go to this region here on the medial side, and that is what you need when you want to bring the leg from lateral to medial, you have about 6 muscles that are innervated by the obturator nerves. So the obturator nerves is an important one, and not everybody knows where to find it. So I will show that to you. Sorry, I have to bring it up a little bit difficult. Yeah. So what I'll do is I'll show a few of these muscles. Okay. Any idea what is that muscle here? This one? So we are now on the inside of the leg. We have the adductor muscles. This is the adductor longus. Okay? Just below that is the adductor brevis. So adductor longus, adductor brevis, and this is the adductor magnus. We have nerves in between those, yeah, between the longus and the brevis, that's the superficial obturator nerve, and between the brevis and the maximus or magnus, you have the deep obturator nerves. Now, they innervate obviously all your muscles to bring the leg from outside to the medium side, but they are also innervations on the medial side of the knee. So if you do knee surgery, it may not be enough to do a femoral nerve block. Sometimes you have to do that obturator nerve block as well. It's also helpful if you're doing a TURP, so a transurethral resection of the prostate. Yeah, then you also have to block this nerve. Okay, there are several ways how to do an obturator block for prostate surgery, but this is one of them. Okay, so you have to go high up, very close to that inguinal canal here. So that is very important. Yeah? So the inguinal canal, that is what you need to determine, and use your pencil. Anyway, I've lost it. Is it somewhere here? Ah, it's here. Okay, use a pencil. Yeah, mark your area, spina iliaca superior, superior and anterior, and the tuberculum pubicum. Mark that line because you tend to be too low. That is where you can block 3 nerves: the femoral nerve, the obturator nerve, and what is the third one? one of the longest nerves in the leg. So it's going all the way like this, all the way till here. What is that nerve? Sorry? Sciatic? No, not saphenous. That's correct, yeah. So this is the saphenous nerve. The saphenous nerve branches off immediately very high in the inguinal canal from the femoral nerve. Okay, so we have the femoral nerve, and then you have the saphenous nerve. The saphenous nerve is only sensory. There's no muscle involved. So it's a sensory nerve. So what you need to do, can you put it like this? Yeah? So the saphenous nerve comes all the way from here, yeah, comes here. Can you hold it? You see the bone here? It comes in the middle of the bone, very superficial because there's no muscle in front of the anterior bone here, just in the middle, and goes in here and innervates this area, yeah, especially the inner ankle. So if you have a fracture of your ankle, sometimes this is not blocked by, for instance, a sciatic block. So what you need to do is use a local anesthetic, just on a needle and a syringe, go from the side to the medial side, just superficially under the patella here, under the tuberositas, and inject your local anesthetic 5 milliliters just subcutaneously, and you will block this whole region. Okay, so it's very helpful for fractures, yeah, here, or fractures of the ankle. That's important. So let's resume it. Very 3 important nerves: femoral nerve, yeah, obturator nerve, and a branch that goes all the way till here. Okay, so the same in here. So we have the femoral nerve, the obturator nerve, and a branch going all the way till the inner ankle. Good? Now, if we come to the foot, how many nerves do we have here? 5, correct. Usually they say 4, but the correct answer is 5. Do you know which ones? I'm coming closer to difficult questions now. So the foot innervation, yeah, we have told you already one of them. That's the saphenous nerve. The saphenous nerve is the inner ankle. Other nerves are coming from the back. In the back we have the sciatic nerve. The sciatic nerve goes into this region, branches off into 2 major nerves, the popliteal and the, how you call it, the peroneus or the perineal, yeah? Okay, the peroneus nerve and the popliteal and the tibial nerve. The tibial nerve, in fact, is a popliteal nerve, and on its way in the lower extremities, it's called the tibial nerve. Okay, so the tibial nerve comes on the below the inner ankle. Okay, it comes here and goes straight to the foot sole. The foot sole branching off in a medial and a lateral nerve. The medial and lateral nerve. Okay, and on the outer side, we have here the tibial nerve branching off the sural nerve. So the sural nerve is going behind the outer ankle. The peroneus comes here in between. So what you need to do is mark your ankle here. I hope I do it correctly. And here. Take a line and go just in the midline. The midline you will have here the superficial peroneal nerve. And between the first and the second toe, here, that is where you have your deep peroneal nerve. Okay? Some people have pain, yeah, here. Just give them an injection, yeah, with a local anesthetic and some steroids, and you will see the pain will subside. I've had surgeons have to stand up all the time. I've had a surgeon who came to me have pain relief for that reason. So the peroneal nerves are on this side, the tibial nerves are on this side and behind the outer ankle. So we have the sural nerve, yeah, we have the tibial nerve, we have the two saphenous nerves, the saphenous nerve and the peroneal nerves. Okay, 5 nerves. Now, it's not always easy to show them on ultrasound, but the easy thing what you can do is, for instance, if you go in here, you have here the Achilles tendon, and we have here, it's not working anymore. Yeah, okay. So we have here the Achilles tendon. Can you show it? Achilles tendon. If you take a line here and just feel with your fingers, okay? You feel the artery here. Feel the artery. Yeah. So it should be halfway this line. Okay, so this is your inner ankle. This is your Achilles tendons. Halfway there should be an artery. What you need to do is bring your needle in here, yeah, just behind the middle, and inject a local anesthetic just behind the artery. Okay, and what you can do, pierce it a little bit further down, and you automatically will do the same on the other side with the same injection. So what you do, you do the injection from here, and then your needle will go to the other side and do the same in here. So halfway, just between the artery, okay? So you will block both nerves by one puncture. Is that clear? And just do it by feeling it. Using ultrasound in this region will be very difficult, especially in elderly. It's almost impossible. The innervation, the vascularization is less, so there's not that much blood flow going through anymore. Yeah, and especially in the diabetes patient, you will not find anything. So just use it. If you can't see it, use it then. Okay, now we have to turn on your belly. Turn, yeah. Sorry, is this all clean? Oh, sorry. And anything else that is still needs to be cleaned? Okay, turn around. Yeah. Yeah. I'll bring this up. Okay, the last part of our lecture this morning is the back. The back of the leg is the sciatic nerve, obviously. Now, where is the origin of the sciatic nerve? Where can I feel it? And in fact, it's rather easy. Yeah, I'll show you again. I'm in favor of the easiest part. Yeah? So what I'll do, I'll just put it in here. Now I have to decrease it a bit. Okay, good. And I already see 2 major muscles. Do you know what is this muscle? This muscle on the lateral side. What is this muscle? This is what is this muscle here? This muscle. The biceps. Biceps femoris, okay? If I go on the middle side, what is that muscle? This one? The semitendinosus and especially semitendinosus, semi-longitudinous. Yeah. So semitendinosus, semimembranosus. That's on the medial side. On the lateral side, we have the biceps. Now, if you carefully feel, just relax as much as possible. Yeah. If you carefully feel, there's a groove. There's a groove in between here. So the nerve will be exactly under that groove. You see how to relax the leg? I'll keep it up myself very loosely, yeah, and you can feel it. So that's how you do it. So you go here in the midline, you see your brachial nerve, brachial biceps, yeah, and then you go to the other side. This is semimembranosus, semitendinosus, okay? And then you have to use a little bit. And can you see the nerve coming up over there? Try to find it even better. See it here? That's your nerve, sciatic nerve, and I easily can follow it up till this region here, yeah, till the gluteus muscle. Just below the gluteus muscle is very easy, okay? If you really want to go very high, and sometimes that's necessary, yeah, again, you have to feel it. The gluteus maximus, below that you have the gluteus medius, and below, and then more inferior is the gluteus minimus. So there are three major muscles here. So maximus, that's the thick one, and then the thinner medius, and then the tiniest of the three is the minimus. Yeah. So you see the nerve here. It's like an oval, flat, but very thick, the size of my thumb. So that's the size of your sciatic nerve, so very thick. In fact, it's already two parts, and the popliteal and the peroneus, these two are already there, they are together. So if I just continue, at a certain point of line, I will lose them. Yeah, I will lose it, and then you really need the curved ones to go deeper, much deeper, because what is the origin of the sciatic nerve? Any idea? Obviously, it's the sacral area here, yeah, but it comes between the piriformis on top, and just it lies on, and the nerve lies on the gemelli muscles, gemelli superior, gemelli inferior, the obturator, and then below is the quadratus femoris muscle. You know that? So all these muscles, I will show it in a moment. Okay, now sometimes the nerve is trapped, and they call it the piriformis syndrome. You know the piriformis syndrome? If I push hard here, yeah, sometimes it hurts. And that's, you can look it up under my name. We described the piriformis syndrome years ago, and that's very painful sciatic nerve, and if you push hard, yeah, you can show the patient the pain. The pain will intensify. The only thing what you need to do is a long green needle with a syringe, 10 mils or so, of bupivacaine plus a steroid injected on that spot, and the pain will be relieved immediately. So it's a very useful technique. And many patients I have helped in this way to get rid of their pains, and it's really hard. They hardly can walk anymore. And so it's very useful to do that. Okay, so we have seen here the sciatic nerve. At a certain point of time, it branches off, yeah, about 8 to 10 centimeters above, yeah, above this line here, the crest here. So 8 to 10 centimeters, it starts to branch off. It starts to become very difficult. So why making it difficult if you can see it here? Yeah, so it's better to do it where you see it in an easy way, I guess. But if you want, you still can go lower and have a look. Now I have to go a little bit deeper. Because I need to see the vessels. And you see, especially in a muscular patient, then it's much more difficult to see them. That's okay. 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 So here you see the vessels, and we should be able to demonstrate the branches. I think I see here the peroneus nerve. I see the pulsations here. And I think this is the other branch here. But it's more difficult. Go in the midline, the same as in your lower arm, go in the midline. It's easier. Okay? Good. You can turn around, please. One second. Yeah. There's one more. Sometimes it's impossible to put the patient in this position. Now there's one more possibility. It's not always working, and then you bring the patient in the frog position. Okay? So now what we want to see is, can we demonstrate, yeah, in here, can we see the sciatic nerve from here? And it's not always easy, but you have to push from the back. You have to push from the back and make sure that normally the sciatic nerve is behind the femur, the femoral bone. Yeah? So you have to put it in the frog position and then push it from behind. Let me see if I can show it. Oops. It's difficult to have to do so many things at the same time. Okay, but here you see the sciatic nerve. So you can do it from the front, yeah, to inject it, but only in this position. Okay. I think I've said enough. Shall we do a few slides anymore? Can we do the slides now? Yeah. Okay. Lower extremities. Next one. Obviously, you have seen there are many. Can I go backwards? Yeah. You've seen there are many nerves here. The whole body is full of nerves, and it's essential that you pick up those nerves that are really essential to be blocked. And perhaps it's good that you know that the lumbar plexus block obviously is the lumbar region, and the sacral plexus block is the sacral region, rather obviously. Yeah, but you see the iliohypogastric nerve comes from T12. So iliogastric nerve comes from T12. See that? And the ilioinguinal nerve, the one that comes here, is from L1. See that? Then we have the genitofemoral nerve and the laterocutaneous nerve. So this one here, this one, it's L2, L3. The obturator nerve and the femoral nerve are all from L2, L3. It's just one is more anterior than the other. That's all. The sciatic nerve obviously comes completely from the back, yeah, and they do not come in front, but they go backwards. Okay. We have the sciatic nerve, L4 till S3. We have the cutaneous femoris posterior and some gluteus nerve. Next one. Okay, so you see now on the inside, you see many nerves here. Can you see all these? Yeah. All the nerves. So there are many. You can see little nerves in there. Okay, and this is an overview. Yeah, you see subcostal nerve. Yeah, so all the intercostals, they are here. Subcostal nerves. Iliohypogastric nerve comes off very high. Then the ilioinguinal nerve. See that one here. The genitofemoral nerve. The laterocutaneous nerve. You see here the spina iliaca anterior superior. Yeah, just a finger on the side and one finger up, and you will be able to pierce through the fascia, yeah, the abdominal fascia, and freeze that nerve here. A very important one, especially if there's surgery on the side. And then you have your big femoral nerve. You see it immediately branches off under the inguinal canal. You see that? Yeah. So it does not make a point to inject it here because you will only freeze maybe a few of the branches. Next one. Okay, this is the saphenous nerve. So just in front here, just in front, no, just do it like this, yeah. So this bone, you can feel the bone. This is only 3-4 centimeters. Inject your local anesthetic here, and that's all what you need to do to freeze the saphenous nerve if there's a broken ankle. That's most of the time that's the indication. It's just a sensory nerve, no motor involvement. Okay, that's this one here. Okay, that's the same, yeah. You see the bone is here. You just have to inject it. There are no arteries there, so that's good. Next, yeah. Okay, so it's important this is the pubic bone, this is spina iliaca anterior superior, and that you make this line, that you are absolutely on that line and not too much below it. That's important. Yeah. Oh, sorry. Can we go back one? And sorry. Yeah. And here you see the obturator one. Huh? The obturator goes also inside. So this is the inguinal ligament. Yeah. The vein, the artery, and the nerve. So you know which side this is. This is the left side, huh? Correct? Yeah. So on this side, so this is the tubercle bone, this is spina iliaca anterior superior on the left side. This is the right side. This is the pubis bone. Here it will be nerve, artery, vein. Here it is vein, artery, nerve. I've seen people doing it incorrectly because they were mixing up the things and they thought they were doing the plexus here. And that's dangerous, because we have the vessels here. Okay, this is the laterocutaneous nerve. This is the sartorius. The sartorius, I didn't show it to you, but the sartorius is the muscle coming from the spina iliaca anterior superior, going all the way to the other side. Okay, going and end up here under tuberositas tibiae. Yeah, so under the patella, tuberositas tibiae. So this is going like this. Yeah, okay. So that's the sartorius. So the sartorius is a muscle that goes all the way from the lateral, extreme lateral, to the extreme medial side. Yeah, these are the obturator nerves, remember? And this is the pectineus, this is the psoas iliacus, but this is the adductor region, adductor muscles. Yeah, here you see it again. So it's so important that you adhere to the pubic bone and the spina iliaca anterior superior and make that line here, because you really need to be just below that line. That's all. Not a centimeter or two below, that's too far away already. Yeah, and you see this is the artery, the vein, and the plexus is over there. The nervus, the femoral nerve. Oops, did I do something wrong? Okay, so we have the fascia lata, and here is the fascia iliaca. Okay, next one, and then here's the laterocutaneous nerve. Yeah, especially for the side of the leg. The genitofemoral nerve and the femoral nerve. You see, they are very close to each other. And usually when you block this one, you also will block that one. This is the fascia lata. And this is around the nerve, the fascia iliaca. Femoral nerve. This is your laterocutaneous femoris nerve. These are the vessels. Okay. A little bit more of anatomy. Femoral nerve, laterocutaneous, and this is the obturator nerve with the deep and the superficial branches. Okay, a little bit more in detail. Oh no, I need to go back one. Yeah. You see here the adductor muscles, yeah. One layer above the other, so the magnus, the brevis, and the longus, and between each of these muscles there's a nerve, the obturator nerve. Okay, see that here. Again, yeah, there's a special fascia iliaca around the femoral nerve, and you have the fascia lata. The origin L2, L4, and more anterior you have the obturator nerves, more posterior is the femoral nerve. And obviously the innervation of the femoral nerve is that region. Okay, so in the midline, the patella, and then the ankle, because you will also freeze the saphenous nerve. Some landmarks, I've told you that already several times. Femoral crease, that's so important, huh? Pubic bone, spina iliaca anterior superior, the femoral artery, the vein, artery, and the nerve. Yeah, that's what you need to do. Needle insertion with nerve stimulator. You actually can see the quadriceps stimulation, patella twitch can be seen, and use a current, yeah, for the muscle twitching, and give some local anesthetics. Sartorial twist, then you really need to adjust it a bit. the obturator nerves. See here, adductor longus, adductor brevis, adductor minus, and in between each time there's a branch of the obturator nerve. Okay, so you can see it here, the anterior and the deep or posterior. And indications, sorry, I have to show you the indications. Indications for the obturator nerve. Suppression of the adductor reflex for transurethral lateral bladder wall resections. That's an important one because surgeons may be very angry with you if you don't block that one. Adjunct to a femoral nerve block and for postoperative pain management of the medial knee joint. So it's the medial part of the knee, and treatment of adductor spasm. So if you have a patient with really spasms like this can be very helpful. So the innervations, you see the obturator nerve is just anterior to the femoral nerve. You see that? It's on the same segments, but a little bit more anteriorly positioned. And this is the sciatic nerve. And obviously we have gluteal nerves, the gluteus maximus, the superior and inferior, and then finally also the pudendal nerve. I've not shown you that, but if you have the sitting bone and trochanter major, and you divide that in two, you also end up in the sciatic position. Yeah, so sciatic nerve lies between the sitting bone and the trochanter major. So we definitely have higher up the femoral nerve and the obturator nerve and lower the sciatic nerve. This is what is in the textbook. Yeah, it's very easy to produce it in the textbook. Ideal wise, what we see here, the biceps, so that's the lateral side. Yeah. And this is the semitendinosus and semimembranosus. Semimembranosus, semitendinosus. Okay? So this is medial side, this is lateral side. You have the sciatic nerve, but in fact it's already a combination of the common peroneal nerve and the tibial nerve. Okay? We call it just here the popliteal nerve, but in fact we should call it all the time tibial nerve. And the tibial nerve goes down with some branches off, and we have the common peroneal with the lateral one. Now, where exactly, you should be very careful. Oh, here it is, my marker. So, be very careful. You feel here the fibula. The fibula head, yes, on the lateral side here. That is where your, oh, okay. That is where your nerve is located. So if you put a plaster around the leg and it's too tight here, sometimes the peroneal nerve is losing its function. So you see the fibula head is here, yeah, and you see the lateral cutaneous peroneal nerve, lateral cutaneous peroneal nerve goes over that fibula head, and if it is too tight, sometimes there's no function and it's all numb. So be careful for that. You see the peroneal nerve branches off here and goes more to the lateral side, but eventually comes, yeah, here in front. So it goes from the lateral side, but comes in front here. Yeah, that's halfway the two ankles, and the deep one is just between toe 1 and 2, just here. Again, the peroneus communis and the tibial one. Another way to show it, the tibial nerve is thicker, more medial. What does it do? Plantar flexion. So the tibial nerve, what will it do? It will do this way, give gas. Okay? Whereas the peroneal nerve will do that. Okay? So peroneal nerve is lateral, thinner, and is dorsal flexion of the foot. Dorsal flexion of the foot. This one, plantar flexion, This one, dorsiflexion. You can do the block also in this position. If the patient really cannot move, yeah, you can ask for a helper and you can do it in this way. Now you feel two tendons here. Feel two tendons? The lateral one, which tendon is that one? A very thick one, like this. That is a, which tendon, which muscle? Can you show it? Can you show this here? So this tendon here, it's exactly under my finger. Can you show that? Which tendon is that one? That is the biceps. You have your biceps here. Okay? And the other tendon, which one is that? That's your semimembranosus and semitendinosus. So you see that, maybe, can you hold this for me, please? So this is one, and this is the other one. Okay? So if you just put two lines in between, and the nerve will be in the middle. You understand? Can I show that here? Not so easy to see it, but anyway, you have here the tendon of the biceps. You easily can feel that by yourself. Okay? The tendon of the bicep here. And this is the tendon of the semimembranosus and the semitendinosus. You only need to do is divide that in two, and that's exactly the spot where you can inject the local anesthetic. Okay, so even if you can't visualize it with the ultrasound machine, you need to know your anatomy, and these are vital parameters. Next. No? Can you go to the... Okay. Now, in the old textbook, they always said, okay, 5 centimeters, maybe 8 centimeters, sometimes 10 centimeters. Yeah, that is what you need to do. So this is the knee, yeah, and you make a triangle, and that's it. Very doubtful, yeah. It's not so easy. I would recommend, if you really want to see it, go in midway here. That's what you can see it. If you go lower and you see where they're branching off, that's also a good place. But it's not always the case, especially in the young muscular man, it's not so easy. In older people, yeah, females often you can see it, but not in muscular man. So, this is now we are on the lateral side here. This is the medial side, lateral side. The tibial nerve usually stays in the midline, and on the lateral side we have the common peroneal nerve. But you see, it starts to become rather difficult if you want to see that on ultrasound. Yeah? You see here the muscles, and here you see the sciatic popliteal nerve in this particular case. Yeah, it's a rounded nerve in here. Yeah. You also can do it from the lateral side. So now you have to do the injection in here. So you see that there's a groove in here, and you can just go underneath. Don't do it, it's not necessary. I can better show it here. Yeah. So this is a tendon here, and you just go above the tendon and do the injection from that side. This gives you opportunity to approach the patient, yeah, depending on the situation. If it is a trauma patient, the patient is not willing to turn on his side or back or whatever. Yeah, it's just giving you options. You put your probe underneath, and you see, yeah, the point of your needle going towards the plexus that you want to freeze. This is in a more sterile environment. This is from the back. I'm not going too deep into this. This is the trochanter major. Yeah. This is spina iliaca posterior this time. This is from the hiatus sacralis. And if you take a perpendicular line, that's the point of entry. Yeah, 5 centimeters. The sciatic nerve is thumb wide, and sometimes it's like an ellipse, sometimes it's more rounded. There are variations, obviously. Yeah. Popliteal nerve here. And here they are branching off. This is the sciatic nerve. You see, in fact, there are 2 nerves. I think long time ago when they described the anatomy, they thought it was 1 nerve, but in fact, I think it are 2 nerves. The tibial nerve on the medial side and the peroneal nerve communis on the lateral side. These are the, let me see whether I can read it myself. See the quadratus femoris. These are the gemelli, I think. And what you see, this is the, how you call it again? Piriformis. So this is the piriformis muscle. And we are looking from the backside, the piriformis overlying the femoral nerve. And the femoral nerve is positioned all over these different muscles, the gemelli muscle, the obturator muscle, the quadratus femoris muscle, okay? And sometimes it's trapped so much that it's causing a piriformis syndrome. So just have an injection over the nerve with local anesthetic, 10 mils, for instance, because you need a little bit of spread, because it's a thick nerve, and you need some steroids. That's all. Okay, so here you see, this is the gluteus maximus, gluteus medius, and the gluteus minimus. Okay, you see that here? This is the piriformis, and under the piriformis comes the sciatic nerve. Then you have the tibial nerve, the common peroneal nerve, and then it branches off. And these are the 5 nerves for the foot, okay? Peroneus superficial, so midway between the both ankles, and then this is the deep peroneal, so between toe 1 and 2. Okay? Yeah, the sural nerve, the tibial nerve, the plantaris medial and lateral nerve, and this is the saphenous nerve. So that's the foot sole. You see 5 nerves over there. Okay? We didn't talk about the pudendal nerve. Pudendal nerve obviously goes to the genitals, yeah, but also to the anal canal. It's more medial than the sciatic nerve. The last one, and that's a useful one, especially if you are operating upon children, but also on elderly patients with phimosis, for instance, or circumcisions, that kind of things. Yeah, you know, this is the fascia, and the fascia of the abdomen usually has a lot of fat, but not the fascia, yeah, in this region. There's almost no fat. You will see a superficial vein and sometimes also the deep vein. So you have to avoid that. But this is the fascia of Buck. Yeah, the fascia of Buck, you have to pierce that. You can feel that if you pierce that. And you have to just to go with your needle like this. These are the bilateral injection needles. That's not necessary. Go perpendicular to the dorsal aspect. Yeah, make sure that you're in this area here. Inject the local anesthetic, and the local anesthetic will find its targets, both dorsal penile nerve, yeah, and anesthetize it. So that's enough, no more than that. You see here the corpora cavernova with the arteries in here, and the corpora sponjosa with the urethra. Yeah, so corpora cavernosa with the deep arteries, corpora sponjosa with the urethra. Yeah, and this is the fascia of Buck. You just have to pierce it, and the local anesthetic needs to go to the both dorsal nerve of the penis. Now that's not enough if you're doing surgery. It's enough if you're doing surgery on children, for instance, with a face mask and some inhalation anesthetic, but it's not enough if you're doing it for adult surgery without any supplemental. Yeah? Then you need to give a subcutaneous injection that freezes also the ventral part. Okay? That's about it, I would like to say. Any questions today? It's a long session, isn't it?
Okay, we've finished the slide session now. If there is any question from the audience or the participant, you may ask the question, and we will give you the microphone for you. Okay.
I would like to give a special applause to him. Well done. Your glasses here. Yes, please.
Okay. Good afternoon, Professor. My name is Charles. I'm from the second year register. I would like to ask about the regimen for the local anesthetic. We usually do combination of two local anesthetic by the long-acting one and the short-acting one.
Always?
Usually, sometimes.
Okay.
What's your opinion about that?
Well, I think the local anesthetic lidocaine, yeah, is producing more muscle relaxation than, for instance, bupivacaine. So I use the local anesthetic just to freeze the skin, so that I'm piercing with longer needles afterwards. But I'm usually using only bupivacaine. But all depends on the situation. If you have a short operation, why should you use long-acting drugs? Perhaps for pain relief, I think that's good. But yeah, there are different opinions about that. There's no clear-cut answer. I think you can defend it easily if you are using the combination of the two. Usually I want to have long-lasting pain relief with bupivacaine, and some are adding opioids to it. So yeah, there's a lot of variation in that. Is this useful?
Yeah, it's very much useful for us.
Is this difficult to follow because you are from quite an end from the model, and obviously I need to do several things at the same time and try to visualize it as much as possible. But I hope you can take home a few of the things that I told you that are useful in your practice, yeah, and gradually build it out to a more profound knowledge on the topic. It's just little things. Know where's your anatomy, know where you have to look at. Yeah, where is it easy, where is it difficult? That is what I wanted to share with you. Any question?
Okay, any more question from the audience? Please raise your hand. Anyone? Oh yeah.
Good evening, I'm Colin. One thing that I want to ask is sometimes when we do block, especially on the upper side, uh, like supraclavicular block or interscalene block. Sometimes we make sure that the local anesthetic is spread around the nerve, but still, even with concentration of 0.25% bupivacaine, sometimes we get patchy block or even like the intensity of the block is not that much. Like they can still do the operation, but the patient still feel pain, so we need to supplement it with general anesthesia, like general anesthesia intravenous medicines. Is it normal, or is there something wrong?
The more you become proficient in doing this block, the more you do this block. In fact, you should be confident that you are producing a full block. Yeah, there should not be a need for supplemental general anesthesia or sedation. That's not the case. But you need to be aware that you put in your block, you wait 10 minutes or 15 minutes, and you check your block. If your block is not correct, perhaps you have to give a second one or a peripheral one. Yeah, but never let the surgeon start if you are not satisfied. Yeah, you only start the block. You only start surgery after you are satisfied.
Okay. Okay, we will open for one more question. Is there anyone who would like to ask a question? If there is no one, then Professor, I would like to close the session and
Okay.
and
First of all, I would like to thank you for coming here on the Saturday. Secondly, my friend Chin. He missed out a lot of what you could see. Because if you're a model, you don't see that much. But anyway, I hope he too can enjoy some aspects of the learning topics of today. I thank also you for the technicians and the technical support, because I could not do without you. And as I told you in the beginning, it's always a pleasure for me to come back to this university hospital. And that's the reason I think I've done it now for 18 years.
oh,
Yeah, and
okay.
that's, well, they made me a professor here as well. And look, I'm a professor at many institutions, but it's also given me a pleasure to be a professor here at this institution. So thank you very much. I hope I can come back next year, for instance, or maybe sooner, I don't know, and that we can handle a number of other topics. Is there any specific topic that you really want to address me? Please let me know. I hope this one particular was useful and was very practical, but we can do other things as well. Okay? Take care of yourself. Make sure that you can refresh a little bit after this meeting. But it is based on anatomy knowledge. I can't do anything else. And you need to find out if the patient has normal anatomy or maybe a little bit of an aberrant anatomy. So please take care of yourself, and till next time.
Okay.